All right, let's do a quick review on our sepsis form. So patients who come in who meet that sepsis criteria, right? So they've got a sign of infection, right? So they have to have that infection or that concern for infection. And they meet SIRS criteria, so systemic inflammatory response syndrome criteria. So in our hospital, that is a heart rate greater than 90, a blood pressure less than 90 systolic, a respiratory rate that's greater than 20. And then there's also some lab tests, things like lactates that are greater than 2, some white blood cell counts that are either too high or too low, and some platelet and bilirubin results that might trigger a patient to become sepsis positive. So regardless of when the patient becomes sepsis positive, whether that is a patient who's out in triage, or once we start to get some of our lab results back, they screen sepsis positive, then we need to start and use what we have as the sepsis form. All right, so this Sepsis Huddle check sheet was designed to help make sure that the entire team caring for the patient who is screened positive for sepsis, we're all on the same page, we're all on the same timeline. So it's really important that we ensure that these things are happening and that they're happening in order. All right, so first things first, we want to make sure if our patient screens positive, we get the team together. A sepsis huddle can be called by a nurse, by an EMT, and obviously one of our docs. So anyone can do this and get this process started. These forms live at the secretary desk or the unit supervisor desk and should be grabbed for any single one of those patients. Go ahead and put the label on there for the patient so we ensure that the information stays with the patient. You'll notice on here that we have a section that is for time 0. That is the time at which the patient screens positive and we start this bundle. All right, and then we're gonna choose a 3-hour timeline out from there. That's when we wanna have the majority of this met. Okay, so we're looking to do all of these things within that 3 hours. Now, world has changed, right? We've got patients who meet sepsis criteria, but we're really looking at a COVID patient. That is when we start this huddle sheet, that is when that conversation is starting. Are we gonna run this patient like a sepsis patient, or are we gonna do something different because we think this patient is COVID? That's what's happening when we begin our huddle. Okay, so all those conversations should be occurring, okay? The next things on here, obviously, is we're gonna differentiate if our patient meets severe sepsis. We need to get a weight in there because that weight is how we calculate out our fluid resuscitation. And we're gonna draw that lactate and we're gonna put that lactate on there. Again, what we're trying to do is keep everybody on the same page. We wanna make sure that when we draw those cultures, so hopefully you've had a chance to view the SteriPath and how we draw our blood cultures here. If you haven't, make sure you do that. But once you've drawn your 2 sets of blood cultures, then we can go ahead and start our antibiotics. Now, I'm gonna tell you, blood cultures are really important. We really need to have 2 sets of them done before we start our antibiotics. But if there's some reason that we're not going to get that second set of cultures in before we start our antibiotics, we need to do a good job of documenting that. The antibiotics are the fix. Antibiotics are gonna make your patient feel better, not the cultures, but the cultures are really, really important. What we're finding is sometimes, even though we are drawing 2 sets of cultures before we start the antibiotics, we're not doing a good job of documenting the times. Either we're scanning the antibiotics before we've scanned in the cultures into soft ID, or we're making some mistakes there. Make sure when you're doing your sepsis inside of Epic that you're making sure that you're timing these things correctly. That we're timing that we did our blood cultures before we started our antibiotics. We know we're doing the right thing. We do an excellent job when it comes to caring for the sepsis patient. As a matter of fact, at this hospital, we are in the top 1% of the nation in how we manage sepsis patients. But we kick ourselves sometimes when we just don't do a good job of timing our documentation correctly. So that's a really easy fix to make sure that we're doing it right. Okay, then we're gonna go ahead and we're gonna start our antibiotics. And down here, pharmacy gave us a really great resource so that we can make sure that we're using the right antibiotics for sepsis. All right, then we're gonna go ahead and make sure that we're starting our fluid bolus as well. Remember, many sepsis patients, especially the really, really sick ones, they're gonna go into what we call a distributive shock. And so volume becomes very important for them. The SIRS criteria that this patient meets means that very likely their vascular bed is leaking, and it's leaking some of that fluid out of the vascular bed, and they're vasodilating, which is good at a local level, not so good when it's systemic. So we want to make sure that we're giving that volume resuscitation. Now, there are some concerns, obviously, when we're giving volume, right? We worry, especially with like our CHF patients, are we giving them too much? Maybe our other patients who just don't look like they can handle the amount of volume and in the speed in which we want to give it to them. But keep in mind, our job is to be watching for signs of fluid overload. Don't just assume your patient's going to be fluid overloaded. Check them. Lung sounds are a great way to do that. Ask patients how they're breathing. You're looking at their pulse ox, things like that to help identify if this patient is getting fluid overloaded. And if it looks like they're going to be, have that conversation with the physician and make sure that the team is all on the same page. Following that initial bolus, you need to get a second lactate. You seem to be falling out on that sometimes. So we want to make sure we're getting that second lactate. We're looking to see, is it going down? Is it trending down? Or is it still trending up, which means we might need some more volume resuscitation. Make sure too that we're checking blood pressure. We have to have 2 documented blood pressures that are, hopefully improving in that patient within 15 minutes. So we need to make sure that we're doing those vital sign checks. Now, in a sepsis patient who's sick, we really should be doing probably Q15 minute, if not Q5 minute vital signs, depending on how they look, on all of these patients while we're resuscitating them in that first 3-hour bundle time. But make sure that those get documented, that we're not just looking at them on the monitor and noting them in our head. We need to make sure it gets into the documentation. So if we have a patient who's meeting the signs for septic shock, so that might be someone who has a systolic blood pressure even after fluid resuscitation that is less than 90, or a patient whose lactate remains above 4 even with fluid resuscitation, now they're classified as having septic shock. And so we may need to consider additional fluid resuscitation as well as some vasopressors. Levophed tends to be our drug of choice, but it's not the only one out there. And we want to make sure that we're trying to keep that MAP greater than 65. And then last thing is we need to know, where is this patient going to go? If they're in septic shock, you know they're going to the ICU, but if they're starting to improve, they might be able to handle a lower level of care. Make sure this form gets filled out on every single sepsis patient and that all the information is filled out, and make sure it gets turned into your unit supervisor.